Today we are going to talk about osteomyelitis, right? We'll talk about its pathology as well as its relevant clinical medicine, right? So first of all, what is meant by osteomyelitis? Osteo mean bone, myelos mean bone marrow, right? Itis mean inflammation. So what is osteomyelitis? Inflammation of bone and bone marrow, right? So what is osteomyelitis? Inflammation of bone and, yes, bone marrow. But it's almost always due to infective organism, right? So basically it should be considered a infection of bone and bone marrow. So what is osteomyelitis? Osteomyelitis is inflammation of bone and bone marrow, which is virtually due to, it's almost always due to infective organisms, right? Most commonly, these are either pyogenic or non-pyogenic. Non-pyogenic infection of bone or bone marrow. Now, most commonly, either it is pyogenic or non-pyogenic. Pyogenic means pus forming. There are bacteria which are involved, microbes which are involved, which lead to the formation of pus. Is that right? And non-pyogenic organisms are those organisms when they damage the tissue but they don't produce the pus. Now, in those microbes which produce pyogenic osteomyelitis, the most important and most common is Staph aureus. Staph aureus. In 80 to 90% of the culture positive cases are due to Staphylococcus aureus, right? And then there are many other pyogenic organisms which I will discuss later in detail, right? But in the beginning, I just want to put in your mind the most common organism is? Say it loudly. Staphylococcus aureus, right? It's the most common organism. Why? It is, you need to remember that because when you suspect a case of osteomyelitis, and before the culture and sensitivity reports come, you have to start the antibiotic therapy, empiric antibiotic therapy. In that case, the drug should cover Staphylococcus aureus, right? Later on I will tell you, there are certain conditions in which we suspect some specific type of organism to be present more commonly. For example, later on I will discuss that patient with sickle cell disease, they can have osteomyelitis due to Staphylococcus aureus, and also they can have osteomyelitis very commonly due to Salmonella. Is that right? In the same way, if I talk about the osteomyelitis in adult and sexually active persons, it may be due to Neisseria gonorrhea, right? So these special conditions and their associated microbe I will discuss later. In the beginning, you just remember that most common organism producing pyogenic osteomyelitis is Staphylococcus aureus, and most common organism which produces non-pyogenic osteomyelitis is Mycobacterium tuberculosis. Mycobacterium, yes, tuberculosis. Even though there are other organisms as well, fungi can also produce osteomyelitis, but again, most common organism in non-pyogenic osteomyelitis is Mycobacterium tuberculosis, and when Mycobacterium tuberculosis involves the vertebra, spine, the condition is called Pott's disease. When Mycobacterium tuberculosis, right, involves which bones? Vertebra, right? Spine, then condition is called Pott's disease. Right? Now, question is that bones are usually deep. They are covered by the skin and some soft tissue, And a very important membrane which protect the bone from the infections, that is periosteum. If bones are protected so well, then how the organism reach there? How the organism produces inflammation there, right? It means how the next point which we should discuss, that is that route of arrival of organism, that how the organism reaches to target bone to produce osteomyelitis. Entry, route of entry or arrival, that how organism reaches a specific bone to produce osteomyelitis. Especially in children, the commonest pathway is hematogenous, right? Most common is hematogenous pathway, hematogenous route. It's common in children and it can also occur in adult, right? That organisms which produce bacteremia, they may get entry into bone. Especially in children, the most common part of the bone, let's suppose this is a long bone, and as you know in children this is a growth plate, epiphyseal plate. Here is also epiphyseal plate, right? Now, in children, long bones have special areas where bone is growing. This part is diaphysis, here it is epiphysis, and this part of the diaphysis which is contributing to the growth of the bone, this is called metaphysis, right? What is this? Diaphysis, right? And that part of the diaphysis which is growing, it means the ends of the diaphysis which are growing in children, these are called metaphysis. And upper part is, yes, epiphysis. A little detail, and here is, yes, articular cartilage. Here it is, articular cartilage, and here is a very tough membrane over it. What is this membrane? Periosteum, right, covering the bone. Again, what is this membrane? Periosteum. And here in the diaphysis, there is in the shaft, there is a cavity. This is called medullary cavity, where usually there is bone marrow, right? Medullary cavity. Inside the medullary cavity, it is also lined by a membrane, and this membrane is not called periosteum. This membrane is called endosteum. What is it called? Endosteum, right? But what I want to specially mention, that this part of bone here, right, and this part of the bone, this is the growing part of the diaphysis which is just under the growth plate or just under the epiphyseal plate. This part is, yes, metaphysis. Why I'm so much stressing on the metaphysis? There's a reason for that. In children, the most common site in the bone to get involved in osteomyelitis is metaphysis. Later on I will explain why. Actually, metaphysis has very peculiar type of blood flow, and it has a very high level of blood flow. It's highly vascular, right? And later on I will tell you, vascular arrangement here predisposes this part of the bone that bacteria which are circulating in the blood, they love to settle over here, especially Staphylococcus aureus. Is that right? So in children, the commonest site, in the growing children, the commonest site for osteomyelitis is, say it loudly, metaphysis, of course, of the long bones, right? But in the adult, of course, when you are adult, these growth plates disappear. There's no more metaphysis, and it's no more so vascular. Is that right? But in adult also, hematogenously from a distant site of infection, bacteria can reach to the bone. But in adult, most commonly, they involve vertebra. They involve vertebra, right? Am I clear? So what did we discuss? That what is the hematogenous spread of infection to the bones? It's more common in the children, but it can occur in the adults also, right? Where organism from a distant source, sometimes from very minor focus of infection, minor skin infection like boils, furuncles, or paronychia, inflammation related with the nail bed, or tonsillitis, or some infection in the lung, the genitourinary system, right? Or from gastrointestinal system, right? Bacteria may enter into bloodstream, right? And if bacteria are moving in the blood but not proliferating, we call this condition bacteremia. What we call it? Bacteremia. Bacteremia. So from any focus of infection in the body, bacteremia can occur. And sometimes even from small mucosal breaches like very hard defecation and constipation, or sometimes you are chewing some very hard food that damages the gums or mucosal buccal mucosa. So even such minor mucosal injuries can produce the breaches or cracks through which the bacteria can enter into bloodstream. Bacteremia is a very common phenomenon, right? Normally what happens when bacteria enter into blood flow, reticuloendothelial system phagocytose and eliminate these bacteria. But if due to any reason, if bacteria survive in the blood, then they love to settle in certain areas in the body. In case of bones of growing children, bacteria love to settle in metaphysis, and in adult, they love to settle in vertebral bodies. Am I clear? Yes. Any question up to this? Then, route of entry, one is hematogenous, other is direct extension from neighboring soft tissue infections. From neighboring soft tissue infections. For example, if someone has, let me give you an example, if I have some soft tissue infection in this area, right? Initially maybe that staphylococcal infection or abscess is limited in the soft tissue. But if it is not treated well, maybe one day it damages the periosteum, which is usually resistant to bacteria, it protects the bone. But if periosteal breach is there due to some neighboring infection, then infective organism can enter into bone, right? Classical example of this is ulcer in diabetic foot. This is a typical and classical example. What is that? Diabetic foot ulcer. Let me tell you what's wrong with diabetic foot. The patient who have diabetes, right, they develop vascular disease as well as they develop damage to the nerves, neuropathy, right? For example, if a patient who has severe uncontrolled diabetes and he develops atherosclerosis in lower limb vessels, then naturally vessels will become narrow and blood flow to the foot will be increased or decreased? It will be decreased, right? And this decreased blood flow will produce ischemia of the foot. And you know, when an organ is ischemic, right, can it defend itself against the microbes? No. This is one problem. In diabetic patients, right, there may be ischemia to the foot. Number two, diabetes also damages the nerves, sensory nerves, motor nerves, even autonomic nerves. And if there is diabetic neuropathy in the lower limb, it may result into loss of pain sensations, right? And if there is loss of sensation in the foot, patient will inadvertently, repeatedly damage his foot, and patient may not be aware of that kind of damage. Patient may not be aware that there has been injury to the foot, and he will not take care of that, and infection will easily settle. So if there is ischemia, at the top there is neuropathy, and both will predispose the foot to more infection. At the top, in diabetic patient, WBCs or leukocytes, white blood cells, are not very effective in phagocytosis of organisms and intracellular killing of organism. So what is happening? Foot is insensitive, right? Getting more injured, more breach of the skin, right? More entry of the organisms. At the top, due to ischemia, less blood flow going to the foot, right? So less antibodies and less white blood cells are going there. That further increasing the chances of infection. And then more problem that whatever leukocyte reached there, they are drunk with the high sugar level. They are dysfunctional leukocyte and they are unable to clear the infection. So what really happens? And many more problems. So in diabetic foot, repeated injury and infection to the foot lead to ulcerations. Ulceration means a necrotic part of the skin sloughs off. And when there is foot ulcer, right, what will happen? Microbes will enter into that ulcer. And if that ulcer becomes deep, these microbes will reach to the bones of the foot and may produce osteomyelitis. So this is a classical example of what kind of osteomyelitis? Direct extension from the neighboring soft tissue infection. So in ischemic limbs and in diabetic foot, right, you can get osteomyelitis. Am I clear? Then, third more. Bacteria are directly planted into bone. Microbes are somehow directly planted into bone. They are directly inoculated. They are inoculating in the bone, direct inoculation, direct implantation of or plantation of, what you can say, of microbes into bone. What could be the example? Very simple, penetrating injury. There's a bullet injury, of course skin is compromised, soft tissue is compromised, and if that has injured the periosteum, organism from the skin may enter in. Is that right? So direct plantation, it may be penetrating injuries, then there can be surgery. During surgery, especially when you are doing orthopedic implants, right? When you are putting orthopedic implants in the bones, maybe unfortunately you plant the bacteria also there, right? Then compound or open fractures. If someone unfortunately get severe trauma, an accident or some other condition, and there is fracture of bones, and hematoma of the fracture directly communicate with the skin and external world, we say these are open fractures. Of course, then bacteria can directly reach there. So what did we learn up to now? We learn osteomyelitis is inflammation of bone and bone marrow, but it is almost always due to infective organism. It may be pyogenic or non-pyogenic. Most common cause for pyogenic is Staph aureus, and most common for non-pyogenic is Mycobacterium tuberculosis. And if Mycobacterium tuberculosis is damaging the spine, then it is called Pott's disease. Then we talk that how these organisms reach to bone and produce osteomyelitis. It's very important to know, because number one, bones are covered by skin and soft tissue. Number two, specifically, bones are covered by periosteum, and these are they offer resistance for the osteomyelitis. So due to how the organism reached there? One is organism enter into blood, produce bacteremia, and blood vessels which are going to the bone, organism reaches through that. Hematogenous spread. Second is direct extension from nearby soft tissue infections. And third is direct inoculation or plantation of microbes in the bone marrow. Here I will again ask that if there is hematogenous spread in a growing children, what is the short bones are involved, long bones are involved, or irregular bones are involved, or flat bones are involved? Long bones. Very good. Which part of the long bones? Metaphysis. Very good. And in adult, the most common site is for hematogenous spread? Vertebra. Any question? No. Yes.
How do the bacteria destroy the periosteum?
Okay, he's saying how do the bacteria destroy the periosteum? Bacteria destroy the periosteum the way bacteria destroy many other tissues, right? Very simple. That they produce, normally bacteria, for example Staphylococcus aureus, they are producing highly damaging enzymes. This is one thing. Secondly, when damaging enzyme is there, initially if bacteria is outside the periosteum, surrounding soft tissues damage, inflammation occur, neutrophils come, another macrophages come, they also produce what? Destructive enzymes, oxygen free radicals. All of them not only damage the bacteria or white cells, if all this is happening in the vicinity or in the neighborhood of periosteum or for a very long time, there is every chance they may damage the periosteum. Is that right? Periosteum is relatively resistant, but not absolutely resistant to bacterial damage. Am I clear? So that is why I am saying that if there is soft tissue infection and it's not managed properly, and this infection goes very deep and reaches to periosteum, sooner or later it may damage the periosteum and start osteomyelitis. Am I clear? Any question up to here? Then one more thing, that is osteomyelitis may be acute or chronic, but that I will discuss into detail when I talk about clinical presentation, right? Right now we will talk about that a classical case of osteomyelitis in a young child. Let's suppose we take an example. There's a boy of, it's more common in boys than girls. If boy of 6-year-old and he develops osteomyelitis due to hematogenous spread of Staphylococcus aureus in the metaphysis of, for example, tibia. Then once the organism reached there, what are the biological events and what really happens there? Okay, now we'll talk about that. But before we go into that, I would love to mention the blood supply of metaphysis. I will give very brief review of bone structure, right? So that we can discuss about pathological changes or morphological changes in affected bone during osteomyelitis. As we discussed, first we'll talk about the long bone and it's little bit about its structure and its blood supply, right? Because organism is reaching through blood supply, and later on we will see as suppuration or pus formation occur, that pus formation further compromises the blood supply of the bone, right? So I will talk about briefly about the structure of bone, right, which we have already discussed. This is a long bone. What is here? Epiphyseal plate, growth plate, epiphyseal plate. Here it is diaphysis, here it is epiphysis, and here is medullary cavity. And what is this? Metaphysis. Very good, right? Now, blood supply, first of all, from where the bacteria come, how the bacteria come, and why they settle here. Now we'll discuss into detail, right? Let me draw this area in a magnified way. This is epiphyseal plate, right? Yes, Here is your metaphysis and here is diaphysis, right? Now, first of all, about the blood supply. The diaphysis has a nutrient artery, the main artery, which enters through the nutrient foramen, right? This is suppose nutrient artery and it is entering into bone and reaches, which area is this? Medullary cavity. There it divides into two branches, yes, descending and ascending branch, right? Now, and from this descending branch and ascending branch, some vessels are entering into what? They are going to the cortex of the cortical bone, and others are going to, what is this? Bone marrow. So it means the blood vessels are, these are peripheral vessels, right, which are going to the cortical bone, and these are the vessels which are central and going to the medullary cavity. They are supplying, these vessels are supplying bone marrow, and these are entering into cortex, right? And these vessels will supply inner 2/3 of the cortex, cortical bone, right? Then this vessel will go upward, it will give metaphyseal branches. It will give metaphyseal branches, and these metaphyseal branches, they will make multiple hairpin turn loops, special type of loops. I must draw them more clearly. Now, as branches from this main artery, they are approaching the metaphysis, they reach just under the epiphyseal plate and then make a turn. And with that turn, these blood vessels drain into, what are these? Sinusoid, venous channels, sinusoids. And these sinusoids eventually become together and they go into venous drainage, right? And this venous drainage will go out. Now, this is very important to understand this point. This is a very special type of blood flow arrangement, right? Let me make it larger here. This is the growth plate. Here was the artery, and it made the, what was this? Hairpin turns here, right? Now, and then they were draining into sinusoids, right? Now, if bacteria was in general circulation, for example, it entered from a minor skin infection, it was circulating here, somehow it by chance reaches to this blood vessel, so bacteria will, through this nutrient artery, will enter here, and then it will reach to this loops, and it will love to settle here. Yes, why? It will love to settle here, not anywhere else. Why? The reason is that due to this special mechanisms, vascular pattern, that when blood flow is rapidly coming here, on this turn it becomes very slow. Is that right? And because it is draining into very wide channeled sinusoids, it is draining into very wide channel sinusoids. So blood flow here become very slow and turbulent. Blood flow become very slow and turbulent, and bacteria was floating into that. Now you imagine, if there is a river and it's moving very fast, water, you are in the center, less chances you will hit the sides of the river. But if suddenly river become turbulent, your chances to touch the wall are greater. That is exactly what happens here. That blood flow here suddenly become not only slow but also become turbulent. So bacteria have more chance, yes, they have more chance to be for longer duration present in turbulent blood flow and touch the endothelium and attach there, right, and attach there. This is one reason, right, that bacteria settle over this area. There's one more reason. Normally, if bacteria settle to some area, there must be phagocytic cells which should phagocytose and engulf those bacteria and destroy. In these area, in this part of the bone, there are very few phagocytic cells. So that less phagocytic activity in this area further increases the chance of survival of the bacteria. You got it? Number one, the blood flow pattern favors the settlement of bacteria in metaphysis. At the top, in these areas, phagocytic cells activity is very less, as they are less in number. That also enhances the chance for bacteria to stay and survive and multiply. And at the top, especially Staphylococcus, it expresses some cell surface molecules which help this bacteria to stick the bone component. For example, in the bone, there's collagen, there's fibronectin, Staphylococcus aureus, and even some other bacteria express some surface molecules on their cell wall which help these bacteria to stick with the bone extracellular matrix. So all these reasons favor the bacteria to settle and multiply in metaphysis of long bones in children. Am I clear? So this is from where bacteria come. They come from maybe minor skin infection or sore throat or respiratory infection or urogenital infection, right? Sometimes, or simple bacteremia due to some breach in or GIT mucosa. And once bacteria survive in circulation, if they happen to reach over here, right, then in the bone, in the metaphyseal circulation, which is metaphysis is very vascular, and at the top there is a hairpin turn where blood flow becomes very slow and turbulent. Bacteria love to settle there, right, and then there is no more police. There are no more police there, no more phagocytic cells very active, so they multiply there, and then local environment is very loving because bacteria are expressing surface molecules which help the bacteria to hug the collagen and fibronectin, stay there and multiply. You understand it? So this is the reason why metaphyseal osteomyelitis is most common in children. But then what happens? Once the bacteria get foothold in the metaphysis, then what happens? Let's go forward. Bacteria, let's suppose I will show bacteria green. Now this is green bacteria. These are suppose Staphylococcus. When they will multiply here, they will damage the local tissue. When they will damage the local tissue, then damaged local tissue and bacteria, both of them will produce chemical mediators of inflammation, and inflammatory reaction will occur, right? As you know, blood flow will increase, but specifically the first white blood cells which will arrive here are the neutrophils. So neutrophil will start, yes, arriving here. So what will happen here? There will be protein rich exudate with alive, dead and dying bacteria, alive, dead and dying neutrophils, and after 48 hours, after some hours, neutrophil will start calling macrophages. They will start calling, yes, macrophages. And after a few days, even lymphocytes will come. So what is happening there? That bacteria started settling here. This was step number 1, and multiplying there. Then there was the arrival of neutrophils, and then there was the arrival of macrophages, right? All these bacteria, neutrophils, macrophages, all of them are fighting over there and producing destructive chemical substances, and local tissue get damaged. When local tissue is getting damaged, right, this will become an area where there's pus formation. This will become a focus of suppuration, suppurative inflammation. What is pus? Pus is protein-rich inflammatory exudate. Pus is protein-rich inflammatory exudate having alive, dead and dying microbe, plus having alive, dead and dying leukocytes plus having alive, dead and dying local cells, parenchymal cells. So pus is formed here, right? It's a war zone now. So once focus of suppression form here, now pus will spread. If body defenses are unable to eliminate this bacteria, then this pus will spread. If this pus is going to spread, right, it will spread along the least resistance. Which pathways? Pathways of least resistance. It means we must know from where the pus from this area will go and what it will do. One thing I want to make it clear. Pus will not go upward. Let me show you focus of pus in this way. Right? This is all pus here. Now, first thing, pus which is present over here, it cannot pass through the epiphyseal plate. Why? Because epiphyseal plate does not have these metaphyseal vessels, do not pass through epiphyseal plate. There are epiphyseal vasculature also. You understand? There are epiphyseal vessels also, there are metaphyseal vessels also. But in a growing child who is more than 1 year old, this vascular system does not have any connection with the epiphyseal vascular system. And this cartilage, growth plate, is resistant to the action of, relatively resistant to the action of bacterial or white blood cell destructive components. Due to this reason, in a child which is more than 1 year old, this pus cannot go up. It cannot involve epiphysis, right? And if it cannot go up and cannot involve epiphysis, then naturally it cannot reach to, what is this? Articular cartilage. If pus cannot reach here and it cannot reach here, it cannot reach to the joint, it cannot produce suppurative arthritis while passing through this route. But children who are less than 1 year old, this is important clinically to remember, children or infants or children which are less than 1 year old, in those children some metaphyseal vessels and epiphyseal vessels do have connections. What is the importance of this? It means if children are less than 1 year old, even though infection may start at the metaphysis, but it can go to epiphysis and it can destroy the articular cartilage and it can produce suppurative septic arthritis and damage the joint permanently. It's very important to remember that in infants, if there is osteomyelitis, even though it's metaphyseal, but it can go to, you need to treat it very urgently and aggressively. It can spread to epiphysis and eventually to the joint. But children more than 1 year old, until epiphyseal plate is there, these two circulations are independent. They are not on talking terms. For example, epiphyseal in long bones start closing, this plate start closing at the age of 20 or 25 or 23, depending upon different bones. In adolescence it start closing. But from 1 year up to that age, young adulthood, adolescence and young adulthood, until this is present over there, metaphyseal infection cannot go through this plate to the epiphysis and the joint. Am I clear? Right? So it cannot go to the growth plate. Then where the pus will go? Because as time will pass by, more and more pus will be formed, bacteria will keep on multiplying, white blood cells, neutrophils and macrophage will be recruited more and more, local tissue will be damaged and pus will increase and pressure will increase in that site, and now pus need to escape through those anatomical pathways which are offering less resistance. So it means we need to think, what are special pathways here which offer the less resistance, where pus will enter? Now, where the pus will enter? Let me tell you the microscopic structure of bone here, right? We'll study a little bit microscopic structure of bone here, and then I will tell you pus will enter into special channels and canals. Now, what are those channels and canals where pus can enter? Let me explain here a little bit. Already you have understood this, that this was your nutrient artery, right? And then we talked about there was ascending branch and there was descending branch. And then we talked about what were these? Metaphyseal loops. Clear? That is what you know very well. But previously I told you from here, vessels are going to the cortex, bone cortex. Now, actually here, there are special type of arrangement which are bony substances arranged in a very special way, which is called osteons. Bone is arranged in longitudinal cylinders. Now what are osteons? Let me draw one osteon here. Let's suppose there's one osteon here, right? There's another osteon here. There's another cylinder of osteon here and here. There are multiple, right? Now, I will draw one of the osteon here to show what it is. Actually, in the center of the osteon, there is a canal, right? Around it, what is happening? Around it, there is a canal in which there are blood vessels and nerves and lymphatics. Around it, these are cells, osteocytes, and this is the bone matrix. What is it?
Bone matrix.
Bone matrix, right? Now, what is happening again? There are osteocytes here. What are these? Osteocytes. And these osteocytes are embedded into bone minerals. There is calcium, phosphate, hydroxyapatite, you know these things, right? But inside it, in this central canal, there is a blood vessel. Along with this blood vessel, of course, there is capillaries, and there is venous channels, there are arterial channels, and there are capillaries and nerves. Around this central canal, this all bone structure is there. Is that right? Now this canal is called Haversian Canal. What is it called? Haversian Canal, because through this canal, blood vessel is going down. Haversian Canal, right? And then in this area, I can show you more osteons, or let's suppose this is central canal. Or we can show it here now, right? I will show larger in this area. This is osteon, multi-layers, and in the center, there is, what is this? Haversian Canal. What is this? Haversian Canal. What is this? Haversian Canal, right? And these are, am I clear? Bones are arranged in small cylinders, right? Now, if I show you Haversian, if I cut a section of it, how it will look? This is one osteon I cut. Now these are its lamella. These lamella are around the central channel. So these lamella are said to be concentric lamellae of bone. What are these? These are concentric, because this is the center. They are concentric lamellae of bone, right? And here, now what is this? What is this canal you can see? Haversian Canal, right? And here are these lamellae. Am I clear? I have made a section on longitudinal section that here are the horizontal section, right? Now, if I draw here one more, here is also Haversian Canal and blood flow. Now this is one channel, but actually these channels, they are connected on the sides. For example, from here I can show on the side, there are horizontal connections, right, to the neighboring Haversian. For example, from here, a channel is connected to this. This is central Haversian Canal, but there is a connection which is horizontal or oblique. This is called not Haversian Canal, this is called Waxman Canal. Upper, these longitudinal are Haversian Canal, right? And these horizontal or oblique interconnections are man canals. Is that right? Actually, blood is given to the, all of them are interconnected. For example, it may be connected with this, right? This may be obliquely connected with that. You are understanding? Now, if I make it here more largely, this is one Haversian system. There is another other Haversian system here, or osteon with Haversian canals. Now, what did I show? This is the blood vessel here. Is that right? And there is a blood vessel here, right? And they are interconnected through which? Waxman Canal. Is that right? Now, from where the blood is entering into this system? Actually, these vessels. This vessel is coming as Waxman. This vessel will come and supply as Waxman and eventually enter the blood into Haversian system. Is that right? Then, not only the blood is coming from medullary site, blood is also coming from periosteum. Let's suppose this is periosteum. This is outer periosteum. Actually, main artery is nutrient artery, but there are many small periosteal arteries also coming. And these periosteum arteries, they pierce the periosteum, enter into cortical bone, and then they also supply as Waxman. Do you understand it? So what is happening? From inner side, horizontal entry of the blood channels as Waxman, and from periosteum, Waxman. And these are connected with Haversian canals, and they are also interconnected with Waxman. So this is how the bone substance in this bone is given the blood flow. Am I clear? Yes. Any question about this? Now, if I make it very simple diagram. Now we come over here in this diagram and we see, let's focus here. These are the Haversian systems. Let's suppose these are Haversian systems, right? And what are these? Waxmans. And from here, this is periosteal blood vessel. It is also giving what? Waxman. And then they are interconnected with each other. So this is the blood supply in this area. Of course, what should be here? What is this? Periosteum. Right? Any question up to this? No. Now, as I told you, let's go back. I was telling as time is passing by, more and more inflammation, more and more suppression, and it cannot cross to the epiphyseal plate, then it need to spread, yes, into Haversian system, right? And this pus will even go in this direction and enter through Waxman system, and even pus will go outward. Through which pathway? Waxman, and go where? Periosteum. And eventually subperiosteal abscess will form. What will form? Subperiosteal abscess will form because now pus has destroyed the tissue, can reach directly here, or pus through the Haversian system can come over here, and the pus which is accumulating here, it pressurizes or strips away the periosteum from the bone surface, pulls away. Then periosteum is lifted away, more damage occurs. You know how? The blood vessels which are going through the periosteum, they are cut off. Blood supply to this part of the bone is cut off. Right? So let's move. I will explain again this part, that exactly what is happening there. Now you will rapidly review what we have done and then we'll move forward. We'll see as the progression of the disease, as time passes by, what really happens there. Yes, there was the medullary cavity. Now rapidly, which is this artery coming? Nutrient artery, up and down, and metaphyseal vessels, right? And these were the vessels going to the Walkmans. Here was which vessels? Periosteal. Is that right? Yes. Bone is a living tissue, of course. Inside it, what are these systems? Haversian systems. And what are these connections? Walkman. Is that right? Any question up to this? Here was pus started, right? It could not go up. Oh, we need to put the epiphyseal line. Okay, we'll take it off. You know, that's the beauty of drawing as you want. So this is epiphyseal plate. Now pus cannot go up, right? What it has to do, but before we go for that, what is here? Periosteum. And what is here? Endosteum, right? What happened? This pus entered into Haversian Canal. This pus damaged the bone and went into under the periosteum. Directly by destruction of the bone, or through the Haversian Canal and then Walkman Canal. Plus this pus went to the medullary cavity, and in the medullary cavity again it entered to the cortical bone through Walkman's canal. Eventually, as time passes by, there's a very big tragedy there. The tragedy is this, that this pus which was originally here, now it has gone into Haversian system. Yes, it has gone from here to which area? Walkman system, and from here subperiosteum. Is that right? Yes. Subperiosteal arrival of the pus. Is that right? And from here also Walkman. So all these vascular channels, pus is entering. They are not expansile. So all these blood vessels will be compressed. All these blood vessels will be compressed and they will be destroyed and they will be thrombosed. Do you think blood circulation could be maintained in this part of the bone? No. So blood flow to this area will be compromised and this will produce severe ischemia. This part of the bone will become severely ischemic. Why? Due to entrance of suppurative process in Haversian Canal then Walkman Canal, right, leading to compression, destruction and thrombosis of these vessels and severe ischemia of the underlying cortical bone. Am I clear? And meanwhile, pus has reached under the periosteum and it lifts the periosteum of the bone. And when periosteum is stripped away, periosteal blood vessels, these blood vessels are also broken away and blood flows is another source of blood flow is lost. Now blood is unable to enter from medullary side, which supplies the inner 2/3 of the cortical bone, and blood failed to enter from periosteal side, which normally supply blood to outer 1/3 of the cortex. Is that right? And eventually this part of the bone, this segment of the bone, do you think it can live now without blood flow? No. So what will happen? This will undergo very severe ischemic necrosis. This will undergo very severe ischemic necrosis. This will be a necrotic bone. This is very dangerous bone. You know why? Because on all sides it is surrounded by pus. On all sides it is surrounded by pus, and it is not connected with any functional vascular system. And if it is not connected with any functional vascular system, antibodies cannot come here. Even antibiotics cannot come here, because antibodies and antibiotics need to come here through the blood. And this is now not having circulating blood here. So this is the area, this dead piece of bone, this is a dead piece of bone becomes the haven for bacteria, because then bacteria multiply in this area, and you cannot eradicate by just giving antibiotics or by having a strong immune system. Only antibodies and antibiotics cannot reach here and eliminate this focus of infection. This is the point where we say osteomyelitis is becoming chronic. It has become chronic, and chronic osteomyelitis cannot be treated by antibiotics alone. You need to contact the orthopedic surgeon. You need to get this dead piece of bone out. This dead piece of bone, this is called, yes, it is a very special name. Who will tell me the name of this dead bone which need to be removed if patient need to be recovered? This is called sequestrum. Sequestrum. This dead piece of bone is called sequestrum. Now you understand how the sequestrum forms and why it forms, how the vascular compromise occurs. So if a patient with acute osteomyelitis come, and if diagnosis is delayed or appropriate or adequate antibiotic treatment is not done, there's a chance sequestrum will form. And biological system is not so helpless, still we will fight. System will fight against this. What is happening here? How the system will fight? In the periosteum, a special reaction will come to help the situation. Actually, as I told you, first bacteria, then neutrophils, then macrophages, and around after the 7th, 8th day, even lymphocytes, chronic inflammatory cell come. Acute inflammatory cells are classically neutrophil with macrophages, but later on macrophages with lymphocytes. When this process converts into chronic, and lot of chronic inflammatory cells are here, they are producing cytokines. These cells are secreting, releasing cytokines, interleukin 1, interleukin 2, and then there is tumor necrotic factors and many other substances. For prolonged release of these cytokines stimulate the, what is this? Periosteum. And also they stimulate the endosteum. The periosteum which was lifted away and endosteum which was also stripped away, right? There are cells inside the periosteum and endosteum which are sleepy cells. These are called mesenchymal osteoprogenitor cells. What are these? They are cells inside which are called mesenchymal osteoprogenitor cells. These are mesenchymal cells, not well differentiated, but if they are differentiated, they can produce the bone, right? So what happens? When these chronic inflammatory cells are here and there's constant irritation, stimulation of what is this? Periosteum and endosteum and other living bone by the cytokines. The cells, mesenchymal osteoprogenitor cells, which are abundantly present in periosteum and also present to some extent in endosteum, these cells are stimulated. And these cells convert into bone forming cells. They convert into osteoblast. And they start releasing bone components. What body is trying to do? They are trying to make new bone formation. What will happen? There is new bone formation. There was first event was suppuration. Then subperiosteal, endosteal and Haversian Canal. And what was this? Entrance into Walkman's Canal. Then we were left with here, what was this? Yes? Sequestrum. We were left with sequestrum. Then what happens? Periosteum, which was lifted here, it start doing a special thing. And what is that? Start making the bone. In the periosteum, there were what? Mesenchymal cells, progenitor cells, mesenchymal osteoprogenitor cells, which start convert into osteoblast. And not only here, this also occurs in endosteum. So on both sides, the cells become active and they start making new bone. This is called reactive bone formation. What is it called? Reactive bone formation. This reactive bone formation, which is occurring, it will make a sleeve around this pus and sequestrum. This is new bone formation. It is attempt by our biological system to contain or limit the infection and also to strengthen the bone, because after sequestrum formation, this bone is dangerously weak. It can no more support the body weight, or it doesn't have any strength. You understand it? So body is doing its fight. So periosteum mainly, and to some extent endosteum, osteoprogenitor cells are activated, converted into osteoblast cells, and they start making new bone, and there is new bone formation, right? This new bone formation, I will make it red color. This new bone formation, this new bone, right, which make a sleeve or cover around the sequestrum and pus, this is called involucrum. What is it called? Involucrum. Of course, now disease is getting chronic. You cannot get this bacteria out. You know, when there's chronic osteomyelitis, it's almost impossible to eradicate it. Sometimes even you cut off the limb. It's very difficult to get it out. We'll talk about its management later, but what I'm trying to say, it's very important that if you recognize the patient in acute osteomyelitis stage, within first few days, give very aggressive antibiotic treatment. I will tell you later that in different clinical conditions, you suspect different organisms and different antibiotics should be given empirically. And later on, when culture and sensitivity is done, then you do the exact appropriate antibiotic. You are understanding? Otherwise, there will be formation of sequestrum and along with that, involucrum. Right? Now we know how the bacteria reach here and why they settle here. And after that, how they spread and they produce sequestrum. And while the sequestrum is there, subperiosteal abscess is also formed. Subperiosteal abscess was also here. Subperiosteal abscess. So subperiosteal abscess was there, sequestrum is there, and now involucrum is also there. But whatever involucrum is formed, one thing you need to remember, involucrum is like it is not having any Haversian system. It does not have well-defined osteons. So it is not very strong bone. Even though it try to support, but it is much weaker than the normal bone, which has been lost. Is that right? Now, as time passes by, right, Pus is there all around. Now bacteria have made a very safe place for itself, and whatever you are doing antibiotic, whatever body is trying to fight, you cannot get this nidus of infection out of, seed of infection out of here. If time passes by, what will happen? Eventually, subperiosteal pus or abscess may rupture into soft tissue, into surrounding muscles, right? So what will happen? Number one, if there was subperiosteal abscess, that will rupture outside, and eventually some part of involucrum will be digested by this pus, and pus will come out through this to the soft tissue. You are understanding what is happening now? And this opening through which this pus has gone out, this channel is called cloaca. What is it called? Cloaca. So there is cloaca formation which is a hole in the what? Involucrum, through which pus is draining outward, subperiosteally and eventually into soft tissue. Are you getting me? Yes. And even through this cloaca and this surrounding tissue, whatever pus is coming out, local tissues start getting damaged. And let's suppose here is the skin. Eventually, this pus will make a pathway, damage the local tissue, and eventually it appear maybe surface of it make a pathway while damaging the tissues, it come to the surface of the body, and from here the pus come out. This is called, this pathway from cloaca up to the skin through which pus is coming out, and even sometimes sequestrum crumble and small pieces of sequestrum also come out. This pathway is called sinus. So eventually a sinus is formed. What is formed? A sinus is formed. Is that right? Any question up to this? Yes.
Can involucrum be infected?
Of course, involucrum is not only infected, main infection is in sequestrum and around it. Involucrum is a reactive bone formation, but of course some microbe enter there. But there a big fight is going on because involucrum has blood supply. And through that antibiotics or antibodies or white blood cells, new arrival of blood cell is going over there and fight is there. But this base is lost to the pathogens. Sequestrum is lost in the war. Is that right? And eventually they will make a tunnel through the involucrum, cloaca, and subperiosteal area, and pus eventually damages soft tissue very rapidly, and eventually it drains out through the skin, and there is a sinus formation. Is that right? And once the sinus formation occur, as time passes by, the skin epithelium, there is squamous cell epithelium on the skin, epidermis, am I right or not? This epithelium start growing inward. It start growing into the sinus. From outside, it start growing inward. And we say the sinus is lined by squamous epithelium. Sinuses, draining sinuses, eventually lined by squamous epithelium. Once it is epithelialized, it cannot close automatically. It becomes a permanent channel. Once it is epithelialized, it becomes permanent channel. Is that clear? So not only sinus formation, eventually epithelialization of the sinus occur. Epithelialization of sinus occur. So that simple bacteria we reached over here. What did it do? First thing, it settled over here. Why it settled here? Number one, blood flow was turbulent and slow due to hairpin turn. Number two, phagocytic activity here was less. Number three, bacteria, especially many bacteria, including Staphylococcus aureus, express on their surface molecule which help the bacteria to stick with the extracellular component of the bone like collagen and fibronectin. Once bacteria settle here, they will multiply and make local separation, which cannot go through epiphyseal plate. But in children less than 1 year, there are vascular connections between metaphyseal vessel and epiphyseal. Then it can go upward. Or after the epiphyseal growth is finished, in adulthood, then even these two vascular system again develop reconnections. In adulthood, once this disappear, these vascular connection on the epiphyseal side and